warm welcome and an Austrian service to our coverage from ESMO. The Congress of the European Society for Medical Oncology is one of the most important events in cancer medicine and took place in October in Berlin. My name is Claudia Altmann-Pospischek. I am from Austria, and for 12 and a half years now, I have been living with metastatic breast cancer. I'm a patient advocate and blog at Claudia's Cancer Challenge. On behalf of patients today and the breast cancer magazine Mamma Mia, I am very pleased to be here today with one of the leading German women in oncology, Professor Dr. Nadia Harbeck, to take a look at significant new studies that were presented at ESMO together. Professor, would you like to briefly introduce yourself?
Yes, gladly. First of all, I'm happy that we can do this together reporting here about ESMO. My name is Nadia Harbeck. I head the breast center at the LMU clinic in Munich and was also very active at ESMO this year, presenting several contributions. We'll discuss that in more detail shortly.
Very good. We have taken a closer look at a few studies on metastatic breast cancer, which are of particular relevance from the patient's perspective, and now we will focus on the triple negative subtype. And with that, I am happy to hand over to our medical expert, Professor Harbeck.
Yes, thank you very much. Then let's start with our disclaimers, which are always included. Here are my potential conflicts of interest. We'll start with the substance that is our standard therapy in second-line treatment for triple negative carcinomas, the antibody drug conjugate sacituzumab govitecan. At ESMO, we saw a study, the ACCENT-03 study, where this substance was also used in first-line therapy, that is when triple negative disease had metastasized, and specifically in patients who either could not receive immunotherapy or whose tumors had a negative PD-L1 status, meaning that under the microscope after staining, they did not appear immunogenic. And these patients participated in the ACCENT-03 study. The ACCENT-03 study was a comparative analysis. In one arm, patients received the standard therapy, which would be conventional chemotherapy only, which was either a taxane or a combination with platinum, or as a new development, sacituzumab govitecan. This is an antibody drug conjugate that is administered intravenously, specifically on days 1 and 8, and this cycle is repeated every 3 weeks. There were just under 280 patients in each study arm, and the median follow-up data was just over 1 year. What the study showed was that sacituzumab govitecan was significantly better than standard chemotherapy when it came to delaying the progression of the disease. But also, the duration of response was almost twice as long with the antibody drug conjugate as with chemotherapy. And this difference was also highly significant. Here you can see again the slides from the ESMO Congress itself. Javi Cortez from Spain presented the study, and you can clearly see here in the blue curve that patients who received sacituzumab govitecan already in the first line of therapy had a significantly longer time until disease progression. On median, meaning for 50% of patients, there was an absolute difference of about 3 months. And also the progression-free survival too, that is the survival until progression in the therapy line after the study treatment, was still significantly better with sacituzumab govitecan than with chemotherapy. The overall survival data are still very immature, so not much can be said yet. And it must be said, which I think is the very crucial point in this study design, was that patients who were randomized to the chemotherapy arms were able to receive sacituzumab govitecan after disease progression, that is after the end of the study, so to speak, as second-line therapy. This means that it was a conscious decision to provide patients with the approved therapies for second-line treatment, not to withhold it and to make it available to all patients internationally. Because although the drug is approved, it is not reimbursed in all countries, and patients have access to it. If the effective drug is made available to all patients as a subsequent line of therapy, it is possible that if early use is not the decisive factor here, but rather that the drug is given at all, this could potentially mean makes the survival data of the study appear somewhat, in quotation marks, worse, because all patients received the drug in the second line of therapy. But the company consciously accepted this in order not to withhold a life-saving therapy from patients, I must say. This also received applause during the presentation in Berlin. What do we know about sacituzumab govitecan? We use it in the second line routinely. We know it causes changes in blood counts and in part gastrointestinal problems. However, the discontinuation rate was lower here than in the chemotherapy group. This means that patients actually tolerated it well. However, we know that sacituzumab govitecan usually also requires growth factor therapy. This means that after the infusion on the following day, you inject GCSF once to support blood cell production, so to speak, and thereby also prevent febrile neutropenia. The study achieved its primary endpoint. It showed a clear benefit for sacituzumab govitecan in first-line therapy when immunotherapy is not an option. Of course, the extension of approval still needs to await approval, but I think the substance will establish itself in first-line therapy for triple-negative carcinoma. At this year's ASCO, we already saw the ACCENT-04 study. This was a study for patients in first-line therapy who were able to receive immunotherapy. And here, sacituzumab govitecan was combined with an immunotherapy compared to chemotherapy with immunotherapy. Here you can see the two treatment arms. It was a somewhat smaller study with only about 450 patients who were randomly assigned to the two treatment groups. And we have already seen that sacituzumab govitecan is also better with immunotherapy than chemotherapy with immunotherapy in first-line therapy, so that this substance will certainly be added in the future as a first-line therapy with or without immunotherapy for triple-negative breast cancer. What we have seen here now were the quality of life data from this study, and you can see that the quality of life is definitely comparable. Some aspects here, such as daily functioning, emotional well-being, and also pain and insomnia, were significantly better with sacituzumab govitecan and immunotherapy. Some issues, such as nausea, vomiting, and diarrhea, were worse. This means that this is really something where we, as the therapy team, need to work proactively so that patients do not experience gastrointestinal side effects here. The quality of life with the more effective therapy is definitely equivalent compared to chemotherapy, and in some aspects, as you can see quite well here, even better in certain respects. If the small circle is to the left of the one where the blue is, sacituzumab plus pembrolizumab is better, then the quality of life is better. And as mentioned in the areas of gastrointestinal side effects, we have seen that it is worse. This is a very honest feedback from the patients that the therapist simply should have done more here to combat nausea under this antibody drug conjugate. Here it is. Written down again, these are known side effects in the gastrointestinal tract, and this can be well managed with anti-nausea medication already at the time of infusion, simply to prevent nausea from occurring. And as for the diarrhea, this can be managed by prescribing loperamide, which patients then have at home. And when loose stools occur, they can take it, which significantly suppresses the symptoms. But overall, the quality of life was actually better with this truly more effective therapy. So the quality of life data confirm the efficacy data that we already presented at ASCO. We are also waiting for the label extension. And as soon as that happens, I think, as already mentioned, that sacituzumab govitecan will become a new standard in first-line therapy for triple-negative carcinoma with or without immunotherapy, depending on the PD-L1 status of the tumor.
Thank you very much, Professor. So much valuable information. You already mentioned it. Quality of life is, of course, our highest priority, and hair loss is naturally a part of that as well. I saw in the statistics that there is a 55% rate of hair loss with SG, but from my community, I know it differently and see that almost everyone loses their hair. What has your experience been with this?
Yes, unfortunately, that's the case. When these substances were new, we also looked into whether scalp cooling could prevent it. For some patients, it works, although in my experience, even for those where you could say it works, the hair becomes noticeably thinner. So this needs to be discussed with the patients. But on the other hand, the chemotherapies that were used can also cause hair loss as well. This is often not very well documented in these studies because it's something we know. And to be honest, in our experience, it's somewhat underdocumented in standard therapies. With taxans, you can also try to preserve the hair using scalp cooling. For some patients, this works as well, but not for everyone.
Thank you very much. I can say from my own experience that neutropenia is, of course, a common side effect. I have that too. As for the diarrhea, as described, I can only say that I haven't had it at all. No, yes, softer stools, but no severe diarrhea. So the side effect profile is really very, very good, and you can live with it quite well. I just wanted to add that from my own experience. And I think with that, we can move on to the next study. And
Yes, so that's basically where we stand. We're staying in a very similar area, also in the first-line treatment of triple-negative carcinoma, the ASCENT-03 study. So the first study I presented and this TROPION-02 study here, these were, I think, two studies that actually belong to the main studies at this year's ESMO. Later, we'll also hear something about HER2 positive and hormone receptor positive carcinoma. And with triple negative carcinoma, these were certainly the studies that were discussed the most. What was done in this study, Tropion Breast 02, it was also a first-line study, and it was about a new drug, datopotamab deruxtecan, also an antibody-drug conjugate, which is already approved. It is approved for hormone-sensitive disease as the second line or later chemotherapy, if you will. And here, almost 650 patients in the study with about 2 years of median follow-up. And what was supposed to be shown was whether in patients for whom there was again no indication for immunotherapy, this medication could outperform the standard chemotherapy that we would otherwise give in this situation, can replace it. The results of the study, you can see the dark bars, represent datopotamab. The light magenta is the standard chemotherapy, and here too you can see that datopotamab is better in all endpoints, both in terms of response duration and progression-free survival, as well as overall survival. And of course, that's something we rarely see, that we see an overall survival benefit right at the first analysis. And that's why I wanted to highlight that again. Here are the data on progression-free survival. As mentioned, progression-free survival and overall survival were the primary endpoints. So the study is positive for its primary endpoint. And here, in terms of halting disease progression, regarding the progression of the disease, we see almost a doubling of the time with datopotamab, but also a survival benefit here of about 5 months in the median, so almost half a year. Patients do better if they receive this datopotamab deruxtecan as first-line therapy compared to standard chemotherapy. What is also very important is that this study also included patients who had metastasis very shortly after their early stage disease, that is still during or shortly after neoadjuvant adjuvant therapy. They too were able to participate in the study. So these were difficult to treat disease situations, and yet you can see a clear advantage for datopotamab here. In contrast to the ACCENT-03 study, it must be said fairly that not all patients in the control arm received an antibody drug conjugate as second-line therapy. This is an international study, and as I already mentioned, sacituzumab is approved for second-line therapy, but it is not reimbursed by insurers everywhere. So the safety profile of datopotamab is actually very favorable. We have a treatment duration that is twice as long compared to standard chemotherapy. We have hardly any treatment discontinuations, about 4%, significantly less than with standard chemotherapy. And regarding side effects, they are somewhat different from what we described earlier with sacituzumab. We see fewer changes in blood counts with datopotamab deruxtecan than with chemotherapy. However, we do have, for example, changes to the mucous membranes. We have dry eyes. These are things that can be well prevented with appropriate rinsing solutions for the mucous membranes or artificial tear fluid for the eyes. Here you can see again the therapy relevant side effects now for this substance, which is also an antibody drug conjugate, but with a different side effect profile. As mentioned, these eye side effects, which are mainly dryness, can be managed well with artificial tears or stomatitis, which can also be effectively controlled with rinses, similar to some chemotherapies. It is a somewhat different side effect profile than with sacituzumab govitecan, which I mentioned earlier, and also different from chemotherapy. So in summary, one can say the study achieved both of its endpoints. Patients treated with datopotamab deruxtecan live longer than if they receive chemotherapy as first-line treatment. What we also saw was that the response rate was almost twice as high as with chemotherapy. That means for patients who are symptomatic, who have complaints, we have twice the likelihood that datopotamab will alleviate their symptoms. This is especially important, particularly when the disease course is aggressive, with rapid progression after the first therapy in the early stages of the disease. The duration of treatment was almost twice as long. Nevertheless, there were fewer therapy discontinuations. Overall, with these results, this substance from the study is certainly something that will be approved and will become one of the new standards in first-line therapy for triple-negative breast cancer when there is no indication for immunotherapy. The substance is approved for breast cancer, but an extension of the approval for the triple negative situation still needs to be awaited.
Thank you very much. I just checked briefly. The active ingredient was approved in America in January 2025 and in April 2025 approved in the EU, so really just a very short time ago. Can we expect more approvals or other combinations with datopotamab in the future? What do you think? Because the study results read really excellently and the tolerability should also be good, I think.
There was also another presentation on this substance in first-line therapy with immunotherapy. Professor Schmidt from London, in one of those mini oral sessions, which are these very short presentations, presented the data from the Begonia study, where together with immunotherapy, a response was seen in 4 out of 5 tumors, which is about 80% of cases. That means that datopotamab with immunotherapy is an extremely effective substance. And that's why I think that here there will also be further data on immunotherapy. This substance has also been tested in initial disease when not all tumor cells have disappeared after neoadjuvant chemotherapy. In the so-called non-PCR cases with or without immunotherapy, that was the Tropion-03 study. We are still waiting for the results here. That will take a little longer. That means we will be hearing more about this substance. And the good thing is it is already available for breast cancer. That means if there is a particularly difficult disease situation, for example, if there is immediate progression within the first half year after the initial diagnosis, then you can already discuss with the insurers whether it might not be possible, where you could refer to this data, Tropion-02, and offer it to the patient. So the substance is available, and I also think that the extension of approval really won't take too long with such good data available.
That's a nice outlook for the future. Yes, and even though metastasis is a serious burden to carry, I know that from my own experience, these new findings sound like a better and more manageable path, like more lifetime and quality of life, which is exactly what we need. And of course, we are happy about research and development because we as patients benefit enormously from it. I thank you very much for your clear and comprehensible explanations, dear Professor Dr. Harbeck. Your remarks give courage and bring hope, and that's exactly what matters to us. And with that, we have reached the end of this triple negative blog from the ESMO coverage, and I thank you very much for joining us. Thank you very much.